Hello, anatomy colleagues. This is Dr. Alsop, and in this video, we are going to be focused on the joints of the head. And there's two major categories to go through, so we'll work through each one of those. As always, I have learning objectives here. Read through these. I hope you keep these in mind as we work through our discussion. And we'll begin our discussion with sutures, which we actually discussed quite a bit already in our video on fibrous joints, because sutures are fibrous joints, meaning that the bones of the skull will articulate and be connected by a layer of dense, irregular connective tissue. So no cavity here, like you would have in a synovial joint. And the ligaments that's connecting the bone, the solid sheet between the bones, that's called the sutural ligament. So one of those intrinsic ligaments. Sutures are found between all the bones of the skull, and they are only found in the skull. So you won't find a suture in the lower limb. You'll only find them in the skull. Generally, these are classified as immovable, which is true for adult sutures, but in juveniles, these joints are going to be slightly movable. We'll talk a little bit more about that in a moment. As I mentioned, there are sutures throughout the skull, but there are four major ones I want you to be familiar with and actually be able to identify as they are the most prominent. And we will start with the coronal suture. The more common name, sometimes you'll hear frontal suture every once in a while. This suture is going to unite the frontal bone with both parietal bones. And if you think back to the anatomical planes, this suture name makes sense if you're considering the coronal or the frontal plane, so dividing the body into front and back halves. And this is similar for the sagittal suture. If you think of the sagittal plane that divides the body into right and left sides, well, that sagittal suture is kind of dividing the skull that way as well. The sagittal suture unites the two parietal bones. The squamous sutures, and note I said sutures because there are two of them. This is going to be a paired type of suture. And this suture will unite the parietal bone, one of the parietal bones, with one of the temporal bones. So you would have the same thing on the other side on this illustration. And this suture is unique because they look like overlapping scales, like you would have on a snake. And then lastly, we're going to consider typically the most complex of the sutures, the lambdoid suture, which is going to unite those two parietal bones with the occipital bone posteriorly. I want to point out a craniometric point, which is clinically important, and this point is called the pterion. And so what it's going to be is an articulation point between the frontal bone, the parietal bone, the temporal bone, and the sphenoid bone. So where they come together, we call that point pterion. And that's pretty cool in and of itself. But what lies just deep to this spot is interesting as well. And that's going to be a branch of the middle meningeal artery, which supplies structures in the cranial cavity, such as the bone itself, but also importantly, the meninges that surround the brain. Now, imagine if you had a fracture right here at that spot. Think of a blow to the side of the head. That fractured part of the bone could damage that middle meningeal artery that lies just on the other side of the bone. And that could potentially lead to an epidural hematoma or hemorrhage, which is a very serious condition that can lead to compression of the brain. And if not treated, it could cause death. Now, before there are sutures that you see in adulthood or later childhood, we have what are called fontanelles. And fontanelles translates to little fountains, but colloquially, we more commonly hear these referred to as soft spots. So at birth, we have these dense connective tissue regions between the incompletely developed cranial bones. And this will allow for the surrounding bones and the brain that's deep within to grow. And that's very important. Otherwise, if they were the sutures that are immovable, you wouldn't be able to grow in that way. Also, this allows for flexibility as well. Think about getting the relatively large skull through the birth canal. So having some flexibility in this region is important. Eventually, the fontanelles will be replaced by bone via intramembranous ossification, and then the connective tissue that remains between the bone, these are referred to as the sutures. All right, enough talk about sutures. Let's move to the temporomandibular joint, or the TMJ. And unlike the fibrous sutures, the TMJ is a synovial joint, meaning we get more movement here, which is good because this is the joint we need for mastication or chewing. The articular surfaces of the TMJ are going to be the mandibular fossa of the temporal bone. So that is the T in the TMJ. And then you'll have the mandibular condyle of the mandible. So that will be the M in the TMJ. And these are enclosed in the synovial joint capsule, like you have with all synovial joints. But there is something different about the TMJ that is actually within the synovial cavity. So you have an accessory structure in there called the articular disc. And this is a fibrocartilaginous disc. Not all synovial joints have them, but the TMJ does. And it separates the synovial cavity into a superior compartment or subcompartment and an inferior subcompartment. And that allows for different types of movements to occur. So let's talk a little bit more about the movements at this joint. We're going to classify this joint as a modified hinge joint. And let's talk about why. So the major and most powerful movement at this joint is going to be elevation of the mandible. So think of closing the jaw. That's a pretty powerful motion. Depression can be forceful as well, but not nearly as much. And this action occurs in the inferior subcompartment, and that's why this joint is considered a hinge joint. Now, it is modified because in the superior subcompartment, this allows for more of a plane joint type action. So gliding actions occur here, which in this specific joint is called protraction and retraction, or sometimes you'll hear protrusion and retrusion. So protrusion or protraction is jutting the mandible forward, and retrusion is moving it back in place. And if you click on these images, you're able to be taken to a video that actually shows these actions. So this is important in terms of grinding and kind of breaking up the food more during the chewing actions. Now, you may have heard someone complaining and in pain and say, I have TMJ. Well, it would be super know-it-all of you to say, we all have a TMJ, but you are talking about TMD. So that's what people usually mean when they say, I have TMJ. They actually mean they have the disorder associated with the TMJ joint. And so this can be caused by a multitude of things, but it's often caused by some form of inflammation in the area. The main symptom is pain, but headaches can come with this, so a specific type of pain. Crepitus or grinding sounds can occur. You even can lose mobility with TMD. Another clinical consideration is dislocation of the TMJ. So in general, dislocations are a displacement of a bone from its typical place in a joint. So we'll be talking about dislocations in other joints as well. This can be caused by tearing of the articular capsule or tearing of the surrounding ligaments and tendons to help keep things in place. A dislocation specifically of the TMJ almost always happens anteriorly, and it's going to be a displacement of the mandibular condyle from its proper place. So again, these are almost always an anterior dislocation, meaning that condyle will move too far anteriorly. Specifically, it typically passes anterior to the articular tubercle of the temporal bone. All right, we have reached the practice question. So what do you think of this one? Which of the following bones do not articulate with or at the pterion craniometric point? Remember, this is where four bones meet. So which of these four bones? And in general, when we think about where pterion is, it's on the lateral side of the calvaria. Well, we know that the parietal and the temporal bone form a good amount of the lateral wall. So these bones are probably involved. The sphenoid is a very small part of the calvaria, but that small portion is on the lateral wall. So we're going to put this one in there. So we're left with these two. Is it the frontal or is it the occipital bone? Both form smaller portions of the lateral wall. Really, the frontal forms a little bit more than the occipital. But pterion is also going to be located a bit more anteriorly in general. So frontal is going to be our fourth bone, meaning that occipital is going to be our correct answer. It does not articulate at the pterion craniometric point. It is these other four bones, the frontal, the parietal, the sphenoid, and the temporal. And recall, clinically, that's important. That middle meningeal artery can be damaged, leading potentially to an epidural hematoma. Excellent. Thank you so much for your time and attention.